So good evening, all my friends and family and delegates who have invited me over here, the sponsors, Dr. Gupta, Dr. Pendarkar's group. And it's absolutely an honor to be here tonight to talk about whatever I have to say. I'm the only thing that's standing between, between you and the warm, yummy food out there. So I'll make it quick and short so that it's not that bad. I won't torture you too much. Also, my talk is going to be a little bit different than others in the sense that I do not have any significance to present or any data to show. I do understand, and you all know everything already. We had wonderful presentations by the best in the world, and I think that's amazing. There's not a single data that I have not seen today which I can imagine or think of presenting myself. So what I'm going to be doing today is essentially going to talk about a very important breast cancer symposium conference that I have been a very regular visitor to. That is the San Antonio Breast Cancer Symposium. It was started approximately when I was born. And it was started in San Antonio, which is really nowhere in the world on the map. And the most beautiful thing about that is in Texas. It is nice and warm out there, and the symposium is always in December. And the best people from Germany, Hungary, all over Europe, as well as a few from America as well. One of the things that I have seen over there is not a whole lot of representation from our country of India. And I think that's one of the points I would like to make today, is we do need representation from this country in terms of genetic and molecular markers. Because we as a population, we are significantly different, and I'm very proud to be different than any other population. So we cannot use the Ashkenazi Jewish population's BRCA1 or BRCA2 information to determine if people are going to have BRCA1 or BRCA2 mutations in this country. India is a genetically rich, heterogeneously rich population. And it's almost our responsibility, our duty, to be able to give our people the best that we can. So my slides, I can start them on. My first San Antonio Breast Cancer Symposium was 2005. That was when I was doing my breast oncology fellowship, which is not a common thing. As you know, we have surgical breast oncology fellowships, but not so much of the medical breast oncology fellowships, one of the rare ones, by Dr. Carol Fabian at University of Kansas Medical Center. And she did tell me one thing. Once you do the fellowship with me for 6 months, there won't be a podium in the world that you can stand and give a speech and you would ever be nervous or confused or think that you don't know your stuff. So I think today those words do, I do remember her word. Let's just find my talk here. Give me a second. It should say San Antonio. Oh, and because we cannot find. Okay, number one, aromatase inhibitors. How long should we use an AI in the settings, in the adjuvant setting? So these are the things I'm going to talk about, 5 or 6 points today that will make a difference in your clinical practice in applying all of the things that you learned today to the next breast cancer patient that you're going to see. So the question was 5 years of AI versus 5 years of tamoxifen, right? That was the ATAC trial a few years back. Not a few years, about 12 years back. I used to be a kid those days. Anyway, so the results were an aromatase inhibitor is at least 1.5 times to 2 times better than tamoxifen. Perfect. That's wonderful. So 5 years of an AI became the standard of care. Good. Then comes the question, okay, what are these used for? This is used for an ER-positive breast cancer, correct? And we do know that ER-positive breast cancers do not recur typically in the first 4 or 5 years. They recur 15 or 20 years later. So the question comes, should we not extend the use of aromatase inhibitor for longer than 5 years? And that's where the decision was made to make these clinical trials. So they were started about 10 years or so back, and now I think we do have mature data from those trials saying yes, 5 more years of extended adjuvant endocrine therapy with an aromatase inhibitor does improve, the progression-free survival, disease-free survival, etc. There's no overall survival benefit. Then came the question, do we need 5 years really? So meaning 10 years total. What does 7 years would do? Because, and that was my biggest concern, I did not follow the rule of extended 5 years more because I just do not believe in one size fitting all. I just don't believe it. I say if one size fits all, it cannot be a good quality suit that a good tailor has made for you. It must be one of those nylons or stretchable things which don't really fit all that well. Okay, so the point is 5 years plus another 5 years, or 5 years plus 2 years. So that was study shown at San Antonio Breast Cancer Symposium this time. And what was shown was that 2 years of additional extended aromatase inhibitor was sufficient. Case closed there, done. Now, there will be more analysis later on. We'll talk about that next year probably. So let's move on to the next topic. If you're going to give chemotherapy, when should you give it? How should you give it? So I always believe, again, I'm talking about myself and my beliefs looks like here, that if you go to, if there's a war zone and you want to do, make a difference, either you don't go in there at all, A, or if you go in there, then make sure that you go in there and clean up the business. Don't come back with work half done and half-heartedly. So this is a concept, I think, with the chemotherapy. Should we give regular chemotherapy the way we are used to giving doublet or triplet chemotherapy every 3 weeks or so, standard treatment, versus what we call the dose dancing of the chemotherapy. So basically cram up your chemo, make it effective, make it strong, give a nice good blow, get done with it. You will find that you are actually saving the woman, even though the first 3 or 4 months she's going to hate you. But then later on, she'll be always be grateful to you that you saved her life. So that's take home point number 2, is if you're going to give chemo, try to give it in a condensed, strong intention to cure fashion. Support the patient. Of course, it comes with higher toxicity, no questions asked. But you can use your common sense and you can definitely give a better support to the patient. So that's the case on chemotherapy. So let's move on to the third question. We have a lot of young women with breast cancer now, and these women tend to get, ovarian suppression. That does happen. And what do we do with it? After the ovarian suppression for 5 years or whatever, does the ability to have children comes back or not? So we had a little bit of good news there in the study that's shown at San Antonio this time, showing that yes, if you do achieve successful ovarian suppression, ovarian function suppression for 5 years or the duration of the treatment, these women, particularly with an LH-RH analog, then these women, they do tend to get the fertility back and they do well. And I have seen that happen in my practice, and this is well known. Okay, so that's another thing. Again, more research needs to be done on that particular topic, but I think it was kind of assuring to a lot of young women. Fourth study that did touch me was the weight gain, weight loss study published or presented by Rowan Chabowski, one of my favorites in the breast oncology field. I think he's a very good buddy of my mentor, Dr. Carol Fabian. So his study, the study that he presented was essentially if there is a weight gain of 5% or more or weight loss, does it make a difference in the prognosis, the survival of breast cancer? This is something that I found is one of the very interesting things to think about when I attended my first breast cancer symposium in 2005. Young girls, if they become heavy, they do have an increased risk of developing breast cancer later on. Why does that happen? Doesn't make any sense. If you're a little chubby when you're 12, how come you can have a breast cancer when you're 45? Well, that's because of the metabolic syndrome or the IGF-1 and IGF-2 type of biomarkers, which we know cause metabolic syndrome, insulin resistance essentially, and ultimately breast cancer, certain types of breast cancer. what they did this time was to see, this was a huge study, it was a 60,000 women study, about, okay, if the women who were put on the weight, it's an observation study, so they lost 5% of the weight, and they kept it off for a couple of years more. Did it do better? Yes, the answer is yes. So basically, my next patient who comes in, I will give her this lecture that, well, let's try to walk a little bit more and try to lose a couple of pounds in a healthy fashion. Okay, so that was a prevention lifestyle modification study I think was important. What else was important? I think anti-HER2 therapy. So Herceptin is one of my, if you ask me, one of the drugs, couple of drugs that made the biggest difference in my career of the last 15 years. Number one would be imatinib that Stefan just showed. Wonderful stuff, amazing. I was an intern when I sent my first patient for ST571 that became Gleevec later on and became the thing on the Time magazine the next year. So that was amazing. That was year 2000. Or the second drug will be Herceptin. When I was attending my first symposium, I saw all this, sorry to say, nice old men and very nice old ladies standing up, clapping and crying. They literally had tears down their eyes. And I was wondering what's going on here. I mean, I was like, okay, this is like a huge meeting. This was when the TCH data was being presented. We saw the difference, 50% likelihood of survival when Herceptin is used in comparison to when Herceptin was not used. So that was a data that was powerful, was really amazing. Now, that was the adjuvant trials, of course. Now comes the question, do we use the Herceptin for all 12 months? It's expensive, right? Particularly in this country. So we use for all 12 months, or let's say all 52 weeks, or can we get done with 9 weeks? So I think your neighbors, the Finnish people, the study was published, or it was going on for a while. I learned a few things. Finland is a small country, and it is 101 years old now, apparently. And of course, the study came out to be, and I think it's a bummer, that no, I think the Herceptin has to be given for 1 year. The 9 weeks ain't going to fly it. So I felt a little bit, because again, at least 9 weeks would have been something better than nothing, but 1 year if you can afford it. So that's the anti-HER2 therapy discussion. Anything else I can't remember right now? Of course, CDK4/6 inhibitors. We have 3 of them now, right? All this complex name, ribociclib, palbociclib, and the new one is Bcfi. I can't even say it, is worse than my last name looks like. So all of these are extremely good for our younger women. So what about if you're a little older? What about the typical 65, 70-year-old woman? Would she get the benefit from these CDK4/6 inhibitors just the way the young women do? The study was done and it was presented. Yes, they do get a very similar benefit from that. So the next person who comes by in that age group, I would not shy away from using a CDK4/6 inhibitor. Of course, managing the toxicity is a very important thing. And that's all I have for today. I think one of the most important things that we should all learn here is what, networking, gathering the information, having our organic research from this country, because it is huge. And again, sharing, knowledge sharing is important. And that is something that we must make sure that we do. I thank you all, my family, my mom and dad, my very dear friend, Mr. Brashkishore Mishra from the Healthcare Today, makes me feel like a movie star there, recording me, and all the delegates and the sponsors. Thank you so much.
Thank you, for giving such a clear-cut message to the without showing any sweat. You got your message, and since we had running short of time, that's why we are not allowed any questions.
Perfect.
Questions will be asked at the dinner time.
Perfect.
But right now we have to start the inauguration also. Excellent.
No questions asked.
Dr.
Thank you. You're welcome. It can't get any better than this. Thanks.
The next speaker is She's from Mathura. She's Reena Adhikari.